For several years now, we've had these prognostic factors that we've evaluated, and the prognostic factors have been sort of helpful in terms of giving us an idea what the clinical outcomes are going to be for patients. There haven't been a lot of factors that we've identified that have been useful in managing patients until recently. So more recently, when we've been doing the clinical trials, we've integrated the prognostic factors and evaluated the prognostic factors, and we have a little bit better sense of which ones correlate with outcome and which ones we might use to direct therapy. So the symposium this afternoon is a review of the prognostic factors, a review of data that's available in untreated patients and in previously treated patients, and using those prognostic factors and patient characteristics to determine and to sort of personalize therapy to achieve the best outcome for a patient given their individual disease characteristics. The best example is 17p deletion. That's loss of part of chromosome 17 or a mutation of TP53. So the TP53 gene is located on the short arm of chromosome 17. In patients who have 17p deletion, they're missing that gene. We also can detect mutations in some patients in that gene. That confers a very poor prognosis for patients receiving chemotherapy, chemoimmunotherapy. So today gratefully we have several options that are non-chemotherapy options to manage those patients and treat those patients. But that's a great example, an easy example of how identifying what used to be a prognostic factor, but a genetic marker that's been associated and known not to be very well treated or not difficult to treat with chemoimmunotherapy, much better managed with some of the newer agents like ibrutinib and venetoclax and idelalisib. There's definitely an educational gap. There's also an access gap. So I think community physicians need to know how to order these tests. They're not always widely available and may be difficult to access in clinical practice. FISH, I think, is a little bit easier to access, but getting mutation status for TP53 is more difficult, and my observation has been that not many patients have their immunoglobulin heavy chain V gene sequence analysis done in the community. And I think, again, that's an access. It's an education issue, but it's also an access issue. So getting the information out about how important these things are, but also helping clinicians to find out how to get the tests done is an important effort.